Hello, this is the third installment of our six-part webinar series on the integrated approach to thyroid nodules. My name is Dr. Teresa Alasio, and I am from the Cairo Cytodiagnostic Center in Westchester, New York. Just a little information about our center. We are part of the Cairo Diagnostic Laboratory, which opened in 2013. We are a CLIA-certified New York State licensed facility. We opened our cytology division in May of last year, and our Cytodiagnostic Center was constructed in June of 2014. We perform ultrasound-guided FNAs using a sonic touch ultrasound. We perform the biopsy, we process smears and cell blocks and immunohistochemistry on site. I am the Director of Cytology and the Director of the Cytodiagnostic Center. I have had previous positions at private laboratories as a staff pathologist, and I'm also the former Director of Cytology and Clinical Associate Professor at SUNY Downstate in Brooklyn. I received my medical degree from Mount Sinai in New York City, where I did my pathology residency, and I did my fellowship in cytopathology at NYU. I am also board certified in anatomic pathology and cytopathology from the American Board of Pathology. And I hold a certification from the College of American Pathologists in ultrasound-guided FNA, and I'm also actively pursuing endocrine certification in neck ultrasound. At the Cytodiagnostic Center, we promote the integrated diagnostic approach to our patients, where we use clinical, ultrasound, and cytology correlation in order to arrive at the correct diagnosis for our patients. We perform immediate specimen triage from the specimens that we procure from patients, and we are able to take further samples for testing if that need arises. So there's no need for the patient to return for another FNA for further testing. And we also offer verbal reporting for significant and positive findings to our referring clinicians. So as this is a six-part webinar series on the integrated diagnostic approach to thyroid nodules. So far in sessions 1 and 2, we have covered thyroid cytology and thyroid ultrasound. In future sessions, we will be covering molecular testing in thyroid, as well as some interesting cases from our Cytodiagnostic Center. Today, we'll be talking about American Thyroid Association 2014 guidelines for thyroid nodules and differentiated thyroid cancer. So why all this interest in thyroid? Well, there has been evidence that there is a rapid rise in incidence of thyroid cancer in this country, up to 15 per 100,000 people. And this is true of all subtypes, although we all know that papillary carcinoma is the most common. So thyroid cancer has a high prevalence but a low mortality rate. And this mortality rate has not decreased and has pretty much remained flat for the past several decades. The American Thyroid Association has established guidelines on thyroid nodules and differentiated thyroid cancer. The last revision of these guidelines was in 2009. There are new guidelines that are put forth in 2014, but they're still provisional. Nothing's been published as of yet. However, a webcast of a satellite symposium, which was where they were discussing 2014 guidelines, was presented in June of last year. And this webinar is adapted from that satellite symposium. So overall, these provisional 2014 guidelines have had a few overall changes. One is that the number of recommendations has increased from 80 to 100. So there's more recommendations overall. There have been new additions to the panel. There have been new types of physicians that have offered input as to these guidelines. And The new recommendation guidelines are also qualified by a new grading system that is adapted from the American College of Physicians. And these have implications to physicians, patients, and policymakers. So, as I stated, the ATA panel, most of the panel are endocrinologists. However, new specialties are added, such as pathology, medical oncology, epidemiology, as well as additional surgeons. So we have a number of endocrinologists, we have surgeons, we have nuclear medicine, radiology, pathology, medical oncology, and epidemiology. And these are significant. The grading system, as I stated, was adapted from the American College of Physicians, or ACP, and the recommendations that are made are qualified as strong, weak, or insufficient based on the clarity of risk versus benefits and the evidence supporting the recommendations. And these recommendations are made with patients, clinicians, and policymakers combined. So today in this webinar, I'll be discussing the new recommendations in diagnostic testing of thyroid nodules, and that encompasses ultrasound, surgical pathology, cytopathology, and molecular pathology. I will not be discussing new recommendations for the management and treatment of thyroid nodules, although there are new recommendations for that as well. So the first topic, the first area of recommendations that I'm going to cover is for ultrasound. And for these provisional ATA recommendations, there's a new recommendation that takes into account the sonographic features that are associated with the nodule when you're considering FNA biopsy, and not just the nodule size. Previously, the nodule size was the principal thing taken into account. Usually 1 centimeter was the magic number. Nodules above 1 centimeter were biopsied, or below 1 centimeter were not. But now we're talking more about the sonographic features associated with the nodule, as well as the nodule size. There's also additional recommendations regarding multiple nodules, and as well as follow-up of nodules that have benign cytology, and as well as nodules that have not undergone FNA. So the sonographic risk of malignancy is broken down into patterns of suspicion, and each pattern confers a certain risk of malignancy. So it's high, intermediate, low, and very low, as well as benign. So the high suspicion pattern carries a risk of malignancy from 70 to 90%. And these are nodules that have hypoechoic features, nodules that have microcalcifications, irregular margins, nodules that are microlobulated, nodules that are taller than wide, have extra thyroid extension, or interrupted rim calcifications, as well as soft tissue extension and presence of lymph nodes that look suspicious. These nodules should be biopsied. The intermediate suspicion pattern confers a risk of malignancy from 10 to 20%. These are hypoechoic nodules that are solid but have regular margins. A low suspicion pattern confers a risk of 5 to 10%. And these are the hyperechoic solid nodules with regular margins, the isoechoic nodules that are solid with regular margins, and nodules that are partially cystic with eccentric solid areas with or without halos. And these halos can be regular or irregular in appearance. A very low suspicion pattern has a risk of malignancy less than 3%, and these are the spongiform nodules. These are nodules that are mixed cystic and solid, and the nodules that have no suspicious features, followed up by the benign nodules, which are purely cystic, which have a risk of malignancy less than 1%. So what should happen to these nodules? Well, high suspicion nodules should be where biopsy is considered in cases where they are greater than or equal to 1 centimeter. Intermediate suspicion nodules should also be considered for biopsy. And the strength of these recommendations are strong, and there is moderate to low quality evidence for the high and intermediate suspicion nodules. Low suspicion nodules, if they are larger or equal to 1.5 centimeters, biopsy should be considered. And very low suspicion nodules, if they're very large, greater than or equal to 2 centimeters, these patients should have biopsies. Benign nodules should not be biopsied. And it is also interesting to know that FNA is not recommended for nodules that do not meet the above criteria, including nodules that are less than 1 centimeter. So if they don't exhibit the sonographic pattern, then they should not be biopsied. Now, these cutoff criteria can be modified if either of the following are present, according to the ATA, if the patient has risk factors for thyroid cancer, or if the patient has sonographically suspicious lymph nodes. And these lymph nodes should be considered for biopsy. Now, when multiple nodules that are greater than 1 cm are present, FNA should be based on the ultrasound pattern. And this is a strong recommendation with moderate quality evidence. And if multiple sonographically similar low or very low suspicion pattern nodules are present, the likelihood of malignancy is low, and it is reasonable to FNA the largest nodule and observe the others. This is a weak recommendation with low quality evidence. Now, what happens to nodules with benign cytology? Well, the ATA provisional guidelines state that given the low false negative rate of US ultrasound guided FNA cytology and the higher yield of missed malignancies based on nodule sonographic features rather than growth, the follow-up of thyroid nodules with benign cytology diagnoses should be determined by risk stratification based on the sonographic pattern. So what does this mean? For a high suspicion sonographic pattern and the nodule shows benign cytology, it is recommended that the follow-up be repeat the ultrasound and FNA within 12 months. For intermediate suspicion to low suspicion patterns, the follow-up with benign cytology is repeat the ultrasound at 12 to 24 months, and if there's growth, repeat the FNA or continually observe. Now, for very low suspicion nodules, the ones where it's a less than 3% risk of malignancy, and benign cytology, the utility of surveillance ultrasound and assessment of nodule growth as an indicator for repeat FNA is really not known at this time. And if there's repeat ultrasound, it should be at greater than 24 months. Now, nodules that have not undergone FNA, they may be detected on ultrasound and they do not meet the criteria for FNA at initial imaging. The strategy for sonographic follow-up of these nodules should be based on the nodule's sonographic features. So if there are high suspicion features, repeat ultrasound at 6 to 12 months. And if there is intermediate to low suspicion, repeat ultrasound at 12 to 24 months, regardless if the patient has not undergone an FNA. And for very low suspicion, if the ultrasound is repeated, do it at greater than or equal to 24 months. So, and it also is interesting to note that nodules less than 5 millimeters without high suspicion ultrasound pattern do not require routine sonographic follow-up. And if repeated ultrasound, this repeat should be performed at greater than 24 months. So while ultrasound is an indispensable tool for detection and diagnosis of thyroid nodules, the ultrasound findings should be correlated with fine needle aspiration cytology when diagnosing thyroid nodules. And now the new recommendations for ultrasound from the ATA are taking into account the sonographic features as well as the size of nodules when considering FNA biopsy. So next we have cytopathology, and we question what is the role of FNA and cytology in patients with thyroid nodules. So in terms of what the ATA is going to recommend, thyroid nodule FNA cytology should be reported using the diagnostic groups outlined in the Bethesda System for reporting thyroid cytology. Now, this is a strong recommendation with moderate quality evidence. I went over the Bethesda System for reporting thyroid cytopathology in my first webinar, Essentials of Thyroid Cytology. And basically, the Bethesda System has 6 categories, ranging from non-diagnostic to malignant. Most of the nodules that we see and biopsy are in category 2, benign. This also includes not only the colloid nodules, follicular adenomatous nodules, partially cystic, complex nodules, but also nodules associated with Hashimoto's thyroiditis. Categories 3 and 4 are the known as the indeterminate groups, atypia of undetermined significance or follicular lesion of undetermined significance, AUS or FLUS. And category 4 is follicular neoplasm or suspicious for follicular neoplasm, which includes the Hürthle cell neoplasms. Category 5 is suspicious for malignancy, and category 6 is frankly malignant. Now, if a nodule has initial non-diagnostic cytology, FNA should be repeated with ultrasound guidance and on-site cytologic evaluation. This is interesting to note that this is a strong recommendation with moderate quality evidence. And repeatedly non-diagnostic nodules without a suspicious sonographic pattern require close observation or surgical excision. And surgery should be considered if the cytologically non-diagnostic nodule is detected and sonographically suspicious, and growth of the nodule is detected during ultrasound surveillance, or clinical risk factors for malignancy are present. If the nodule has benign cytology, further immediate diagnostic studies or treatment are not required. And this is based on the evidence that benign cytology is usually truly benign, and there is a very low false negative rate in cytologic diagnosis of thyroid nodules. However, if the cytology result is diagnostic for primary thyroid malignancy, surgery is generally recommended. So that should be well understood. However, there can be cases where active surveillance can be considered for patients who have malignant cytology. And these are cases where there's very low-risk tumors, such as a papillary microcarcinoma. If there are no clinically evident metastasis or local invasion, and there's no convincing cytological molecular evidence of aggressive disease. Patients also who are at high surgical risk because of comorbid conditions. Patients who are expected to have a relatively short lifespan, such as patients who have serious cardiopulmonary disease or other malignancies, or patients who are of very advanced age, and patients with concurrent medical or surgical issues that need to be addressed prior to the thyroid surgery. All of these patient cases make a case for active surveillance. Now, when we come to talking about the indeterminate categories, this is category 3, AUS or FLUS, for nodules with AUS or FLUS cytology and no worrisome clinical or sonographic features. Additional investigations such as repeat FNA or molecular testing may be used to supplement malignancy risk assessment in lieu of proceeding directly with a strategy of either surveillance or diagnostic surgery. So patient preference should be taken into account and considered in clinical decision making. So this is going to encompass not only what the molecular testing or repeat FNA cytology, and also what the patient wants to do in terms of their own care. If the repeat FNA cytology and or molecular testing are not performed or inconclusive, either surveillance or diagnostic surgical excision may be performed for an AUS or FLUS thyroid nodule, depending on the clinical risk factors, sonographic features, and patient preference. So again, this is the ATA saying that, you know, you should consider, you can either perform active surveillance or diagnostic surgical excision, depending on what the patient wants to do, and also based on the sonographic features. When surgery is considered for patients with a solitary cytologically indeterminate nodule, thyroid lobectomy is the recommended initial surgical approach. This approach may be modified based on molecular testing when performed. And continuing on, a further recommendation for surgery for indeterminate nodules, because of the increased risk for malignancy, the total thyroidectomy may be preferred in patients with indeterminate nodules which are cytologically suspicious for malignancy, or nodules that are positive for known mutations specific for carcinoma, such as BRAF, or nodules that are sonographically suspicious, very large, meaning greater than 4 centimeters, or in patients who have a family history of thyroid cancer or history of radiation exposure, if the completion thyroidectomy would be recommended based on the indeterminate nodule being malignant following lobectomy. So basically, if the patient has a malignancy seen on frozen section after the lobectomy, a completion thyroidectomy would be performed. And what they're saying is that if all of these other factors are taken into account, the total thyroidectomy can just be gone straight to surgery. And if patients with indeterminate nodules have bilateral nodular disease, patients who have significant medical comorbidities, or those who prefer to undergo bilateral thyroidectomy to avoid the possibility of requiring a future surgery on the contralateral lobe, these patients may undergo total or near total thyroidectomy initially, assuming completion thyroidectomy would be recommended if the indeterminate nodule proved malignant following lobectomy. So in the cases of follicular neoplasm, and these are follicular neoplasm, which is a category 4, the diagnostic surgical excision is the long-established standard of care for the management of follicular neoplasm, suspicious follicular neoplasm, or class 4 cytology nodules. However, if there are no worrisome clinical or sonographic features, molecular testing may be used to supplement malignancy risk assessment data in lieu of proceeding directly with surgery. Informed patient preference and feasibility should be considered in clinical decision-making. And if the molecular testing is either not performed or inconclusive, surgical excision may be considered for removal and definitive diagnosis of a category 4 nodule. So in summary, for cytology, recommendations concerning the reporting of thyroid cytology will facilitate communication of cytologic diagnosis, meaning the Bethesda System is used across the board, and people will be able to communicate with each other and understand what each pathologist is talking about. And recommendations regarding the follow-up of cytology diagnoses, especially when molecular testing is involved, will also assist in creating the algorithm by which we incorporate a new technology, meaning molecular pathology, into practical patient care. Now, in surgical pathology, there have also been a few new recommendations. In addition to the basic tumor features that are required for the AJCC or UICC thyroid cancer staging, including the status of resected margins, pathology reports should include additional information that are helpful with risk assessment. And these things may include the presence of vascular invasion, including the number of invaded vessels, the number of lymph nodes examined and involved with tumor, including the size of the largest metastatic focus to the lymph node, the presence or absence of extranodal extension of the metastatic tumor as well. And these are strong recommendations with moderate quality evidence. And it also, in terms of evaluation in surgical pathology, the histopathologic variants of thyroid carcinoma that are associated with more unfavorable or more favorable outcome. More unfavorable variants would include tall cell, columnar cell, and hobnail variants of PTC, widely invasive follicular thyroid carcinoma, poorly differentiated carcinoma, and the more favorable variants would include encapsulated follicular variant without invasion or minimally invasive follicular thyroid carcinoma. The outcome should be identified during histopathologic examination and reported, as well as histopathologic variants associated with familial syndrome. And these include the cribriform morular variant of papillary carcinoma that is often associated with FAP, or familial adenomatous polyposis, a P10 hamartoma syndrome associated with follicular carcinoma. These are also, this is also a variant associated with a familiar syndrome. These should be identified during histopathologic evaluation and reported. So now moving on to molecular pathology, which is the newest field in our site, and probably the emerging techniques and strategies that will be more part of our diagnostic toolbox. So regarding the molecular markers and the guide to decision making, these are best used for cytologically indeterminate nodules. And before the test is done, or pre-test, likelihood of malignancy might depend upon the clinical risk factors that have already been discussed, the sonographic risk factors, which I've outlined a few slides ago, and the prevalence of malignancy within cytologic categories. So these molecular markers are most commonly applied in cases of indeterminate nodules. And when you look for a molecular test, you may look for the performance of that test, the sensitivity and the specificity specifically. The patient preference is important if you're thinking of the patient either to rule in something or rule out something. So when you're considering conservative management, when the patient really does not want to have surgery, you want to look for a molecular test with a high sensitivity and a high negative predictive value. However, when patients are leaning more towards surgical excision, you want to consider a test that has high specificity and positive predictive value, and assuming that this high specificity and positive predictive value would influence the extent of the surgery. So if molecular testing is being considered, patients should be counseled regarding the potential benefits and limitations of this testing and about the possible uncertainties in therapeutic and long-term clinical implications of results. And this molecular testing, if it's performed and intended for clinical use, it should be performed in CLIA or CAP certified molecular laboratories, as reported quality assurance practices may be superior compared to other settings. Of the molecular markers best validated to date, there are basically three. A 7-gene panel of mutations and rearrangements, which include BRAF, RAS, RET-PTC, PAX8, PPAR gamma. Now, this is as of this writing. The gene expression classifier, which is known as the AFIRMA test, and galectin-3 immunohistochemistry. The drawback to the immunohistochemistry option is that you require a cell block for it to be performed, and it also has to be validated clinically in your laboratory. There are many molecular markers in development, including next-generation sequencing panels, miRNA panels, and other gene expression-based panels as of the 2014 provisional guidelines. There have been many of these now exploding on the market, but sometimes some validations still need to be performed regarding some of this testing. So as the molecular testing becomes more prevalent, the new recommendations about it are necessary to provide guidelines for the utilization of this new technology. So maybe in the next revision, we're talking maybe 2019, 5 years from now, we're thinking maybe there's going to be more recommendations regarding molecular testing, and who knows what's that what will happen. And decisions regarding the surgical management of patients with thyroid nodules are incorporating molecular testing results more and more. And patients need to be kept in the loop about which tests are used and what the results are going to mean in their each individual case. So therefore, communication between the patients and those who are ordering this testing needs to be encouraged. These tests are usually very expensive. Patients sometimes, have to rely on their insurance to pay for this, or the insurance might not pay for it. So these are very real considerations that patients face when this molecular testing is offered. So in overall summary of this webinar, new recommendations about the diagnosis of thyroid nodules and management of thyroid nodules and thyroid cancer are coming out soon. They should be published probably by the spring. These recommendations are based on evidence and take into consideration the benefits and risks to patients and clinicians. And today, in this webinar, I've covered recommendations regarding ultrasound, cytology, surgical pathology, and molecular testing, which offer clarity and practical applications to our current practice. So I hope that this webinar has been helpful in explaining some of these provisional 2014 guidelines from the ATA. And I hope that you return for the fourth part of our webinar series. Thank you very much.